Chapter 25. Chapter 25 is covers really the urinological system, the renal system, genitourinary, and then also discusses briefly gynecological disorders, because we do have a few things that from time to time involve the female reproductive system. There's a real brief overview of a couple of male-specific problems in this chapter as well. Luckily, in most cases, renal emergencies are not, or renal problems are not enormous emergencies. Occasionally we have something a little bit more critical, and it really falls more into an obstetrics category, but so like a ruptured ectopic pregnancy or a pending rupture of an ectopic pregnancy certainly could be a major emergency for the possible risk of shock that is involved with that. But for the most part, most of these things are not immediately critical, and so some things that are a little more serious, like people who maybe have missed dialysis, which is kind of an emergent deal. A lot of times we'll end up getting called there for a shortness of breath or something along those lines, and come to find out that they missed their dialysis. So, as with all of our chapters, you really need to read and study the chapter. Simply watching and listening to lectures is no replacement for your actual studies. Once again, as with all the medical emergencies, we say that the advanced EMT education standard is the AEMT will be able to apply fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely ill patient. And additionally, I had to look twice at this one, we'll be able to provide basic and select advanced emergency care and transportation based on the assessment findings for a patient of an acutely injured patient, because we do briefly brush on a little bit of traumatic injury in this chapter, not much, but just a little bit. There is a multimedia video you can watch regarding ectopic pregnancies. We have several objectives listed for this chapter on 628 and 629. Okay, so in renal disorders, negative outcomes of untreated or poorly treated diabetes and hypertension tend to lead us to those renal disorders. So both of those are major risk factors for kidney disease. Many diabetics, poorly treated, or people who don't watch their sugars closely, don't take their medicines as required, don't monitor their own diet. Many of those diabetics end up on dialysis for renal failure. Additionally, people with hypertension, severely uncontrolled hypertension, basically you're putting excessive amounts of pressure on the little itty-bitty tiny screens that are found within your kidney, and the excess pressure just basically blows the gaskets and makes it so the kidneys are ineffective. So those aren't the only things that can lead to renal failure, but they are a very high commonality there. The effect on your life from your kidneys is enormous. It's often treatable, but in many cases is permanent. Obviously, we have to be able to take out the waste in order to be able to continue to survive, because we can't just bring in the goods. We have to take out the bads. Otherwise, we build up, we become a very toxic environment. So now, most people can, over a period of time, probably migrate from some cautious dietary restrictions, maybe a little bit of oral medication, may then progress their way into something called peritoneal dialysis, and then probably will eventually end up on hemodialysis. Disorders of that urinary system and the male and female reproductive systems may lead that patient to seek emergency treatment. When are they going to see us? They're probably not going to call us for very specific things. It's probably more generalized things. So maybe abdominal pain, or maybe it's, well, like I said, with the renal dialysis or the kidney failure patient, missed dialysis and now they're short of breath and have a lot of edema. So it's probably not a very specific request. It's probably more generalized. So your think about it goes with your case study on 629 in your text. So to briefly review, we can look at the location of our renal system here. Remember, the kidneys are considered to be in the retroperitoneal space, meaning that they sit behind the abdominal cavity, kind of in two little pouches or pockets on either side of the spine, but outside of the what would commonly be referred to as the abdominal cavity. So they sit just right at the level of your lowest false ribs or your floating ribs there. Roughly towards the top of your lumbar vertebrae is where you're going to locate your kidneys. So of course there's supposed to be one on the right and one on the left. They attach right into those greater vessels there, so they have significant blood supply in and out from the aorta and to the inferior vena cava. They also lead down via the ureters to the urinary bladder, which sits down in the pelvic bowl or in the pelvic cavity. So it sits down there in that pelvic bowl. It's protected well. And then from there, the urethra leads to the outside, or what's referred to as the external urinary meatus. That external urethral meatus is where you actually will urinate from. So remember, we're talking major issues with major blood vessels. We have the potential to be also major issues with our urinary system. So we have the upper urinary tract and the lower urinary tract. Upper urinary tract is essentially the kidneys. That's where our urine is, remember, it is produced. The filtration actually goes on there. It drains from there into the lower urinary tract via the ureters, the bladder, and then finally out the urethra. Diseases of the kidney, the study of that is nephrology, treated by a nephrologist. And then the lower tract is treated by a urologist. Now, some urologists and nephrologists work very closely, or you may have people who have specialized in both specialties. But nephrologists most commonly see people who have taken a trip into renal failure, whereas most people who are having a problem with urination or having a problem with reproduction potentially are even going to see a urologist. So we talked about that they lie in the retroperitoneal space at the costovertebral angles. So what does that mean? But just like I said, at the angle where the lowest floating ribs branch off of the spine, off of the T11 and T12 thoracic vertebrae, that angle basically is right where you're at. So this shows us an example of the nephron. The nephron is the workable unit, the working basic unit of the kidney that actually does something. So we've got a very convoluted mess here, or at least it looks like to be a convoluted mess. So let's start with the red artery there. It's the only red part of this here. So we come off of the artery. This little arteriole then feeds into the what is referred to as Bowman's capsule. Bowman's capsule is where you find the glomerulus, and the glomerulus is the initial sieve or screen, if you will, that sorts a lot of the water, the plasma, and the solids, minus the blood cells, into the system. It will then feed down through the proximal tubule, which winds its way around there. Now you also note that there's this huge network of veins and venules that wrap its way all around this whole system there, including part of it from It comes out the other side of the glomerulus there. So blood enters via the artery. The liquid parts and the smaller solvents or smaller solutes are removed there within Bowman's capsule at the glomerulus, and then some of that blood is going to be sent on down the way. Obviously not all of the water is removed, but a significant amount of it is sucked out there. Then through this through the both proximal tubule, the descending loop of Henle, the ascending loop of Henle, and then finally the distal tubule. With all that intermeshing with that vein, then as needed, salts can be redeposited, more salts can be pulled, water can be pushed or pulled, and so on and so forth. So this gives plenty of opportunities as the body is making its adjustments for it to just real quickly steal back some of what it may be already dumped, or to take out a little bit more than it already pulled. So, and then finally they all wrap back around through the vein down there below the artery, you can see, through the vein, and then of course that's going to feed eventually back into the inferior vena cava. So the urine in its early form, as it progresses to move around through this system here, kind of winds around, eventually is worked on by several of the parts of the system here. The water balance is very delicate there, and the body looks at it and says, okay, exactly how much do I need? Do I have enough out, or can I send some of it packing? Glucose also would be found in here as well, because if the body has excessive amounts of glucose, it can dump it that way. Now through this loop, we have the loop down here, the loop of Henle. Many of our diuretics, and most of you have probably heard of the drug Lasix. Lasix is a loop diuretic, meaning that it works at the loop of Henle, and it prevents it from reabsorbing lots of water, and encourages it to remove more. So this water continues to wind its way around through there with the solutes that are within it, finds its way to the distal tubule, which will then connect into a collecting duct, and those will then all continue to just funnel the urine down into the main part of the kidney, which we can see here. So I want you to imagine this, that we have this nephron that is really the majority of the kidney here. They'll feed down into the pyramids. Those pyramids are really kind of big funnels, and then those funnels will then feed into the renal pelvis and then out the ureter. It's an ever-growing system. I kind of like how they call it pyramid here, because it really is kind of a pyramid scheme where everybody pitches in a little bit and makes a whole bunch in the long run. So we've got millions and millions and millions of these nephrons at this very microscopic view, and so something that they watch, and now we've talked about the glomerulus, something that they pay attention to in most patients with potential kidney failure or kidney issues, is their GFR, or their glomerular filtration rate, which is roughly 120 milliliters a minute, or 7 liters per hour. Well, we don't create 7 liters of urine in an hour's time. At least most of us don't. That's because a lot of that water is reabsorbed. It's just a matter of some of the solids that are getting deposited. Of course, excessive amounts of water, if we're chugging, of course we're going to create more urine. It's going to have more liquid volume to it. In reality, most of that filtrate, like I said, has been reabsorbed. So we're going to produce roughly 30 to 40 milliliters per hour of urine. So you can see that that's a huge amount is reabsorbed. So so we create 30 to 40 milliliters per hour. So kidney failure, they look at the GFR being less than 30 mils per minute. That's something that they look at. It's not something that you just measure urine from. But so that's how they're kind of how they monitor those sorts of things. So remember, a lot of it is truly solid product, although we don't notice it as solid product because we're talking very, very small salt atoms or sugar or what have you. So this urine then funnels its way down there and makes its way into the renal pelvis and then is drained out. So the blood makes its way back into that renal vein and back to the inferior vena cava. All right, so the kidneys, their primary job is to filter the blood. So it's to eliminate the waste. It also is responsible for retaining some of the water. So it's primarily, though, for the other waste products. We obviously know that our gaseous waste products, as carbon dioxide, are gotten rid of via the respiratory system. But some of the other liquid products and some of the solid products are disposed of via the kidneys, and then the larger, the macroscopic solids are gotten rid of via the gastrointestinal system. So you obviously have to have a significant blood supply from the renal arteries in order for this to even work. Once in a while something weird will happen, and the body will create a nice sized blood clot that will actually end up blocking one of the arteries that goes to the kidney. A lot of times I'll refer to it as a saddle embolus because it kind of actually bridges the gap there. But they can create a blood clot that will then go to and block a kidney, and that causes obviously a significant imbalance in our bodies. Now, you can live with one kidney, but for those of us that have been kicking for 20, 30, 40, 50 years with two of them, to go to one kidney, it definitely takes an adjustment. So it's not something that you are just going to immediately adjust to. It takes a little bit of time. So those nephrons are the ones that actually are the workable unit there. They're very microscopic, and they create urine, which is obviously the fluid, majority of it being water, with the other solid waste materials in it. And like I said, collects through the collecting tubules down to the pyramids, to the renal pelvis, to the ureters, and then finally into the bladder. So the outer layer of the kidneys, or the renal cortex, it's where we have the glomerulus and the renal tubules. So if we look at that picture on 631 in our text, that cortex is the more pinkish color there. That's where the actual filtration is going to be occurring. The renal tubules then travel towards the inner layer of the kidney, which is where the medulla is, or those pyramids essentially, and then deposit those into the collecting ducts. Now, in the interstitium of the kidneys, this is tissue that occupies spaces around the tubules and the blood vessels, so it's filler. That filler, if you wanted to think of this, if you created some sort of a sculpture out of wires and hoses and tubes, and then you put a plastic bag around it, and then you took spray foam and filled her up, that spray foam would be the interstitium. It's kind of like what we refer to as the parenchyma of the lung. It's the filler. We talked about the GFR. GFR is roughly 120 mils a minute, or 7 liters per hour, completely. And the glomerulus is responsible for that initial filtration, pulling off that excess fluid from the blood, so it drains off some of the plasma. It begins the process of removing the excess electrolytes. And then it will continue to monitor the pressure within the vessels and readjust the blood pressure. So it watches it as it moves its way through the system. And then also it is influenced by several of the hormones. If you remember, we talked about back in the endocrine chapter, we talked about very, very briefly a hormone that is called antidiuretic hormone. And antidiuretic hormone can work on the kidneys as well when it's sensing the body is either in shock or is severely dehydrated. That hormone then can influence the kidneys to retain more water. So it says, don't give away all of our extras. We need some of that. So hold on to it. There are other things that will affect it too. A lot of the other sympathetic, parasympathetic, remember, works mostly on our rest and digest. When we have a sympathetic response, a lot of times our sympathetic nervous system hits and it overrides and says, hey, retain the extra water until we know if we're going to need it. So that doesn't help you if you already have a really full bladder and you get an ambulance call and have to go running out the door, because that water's already been moved on, but it's the water that's still filtering through the kidneys. So after the urine leaves the kidney, moves down in that lower system, leaves the calyces of the kidney, enters the ureters, goes down to the urinary bladder, and in the bladder, that's the reservoir that holds the urine. And when you get a feeling of a full bladder, you get that urge to urinate or to micturate, and then you'll release your urine through your urethra. Probably worth mentioning kidney stones. Kidney stones are a lot of the residual solids that are filtered out by the kidneys, and typically kind of like when you get drains that kind of get gooped up from hair gel, hairspray, toothpaste, whatever, kind of the same sort of thing happens. This residuals hangs around there, and then eventually kind of starts to goop up and solidify and become a hard little stone that actually, if you look at it under a microscope, looks like a cockleburr. And eventually it gets discharged, broken loose from the kidney, and it's when it starts to migrate itself down through the ureter that it becomes problematic, because the ureter is usually not have the space to pass most of these. So to look at the male anatomy of the genitourinary system, we have obviously from our urinary bladder, which is kind of more or less top of the picture here, underneath the resected portion of the colon and the rectum. So we have the urinary bladder. You have the urethra that comes down out of the bottom side of the urinary bladder, and then will merge in with the ejaculatory duct within the prostate. The ejaculatory duct and the seminal vesicle kind of come together there out within the prostate. So actually, when a man creates sperm, he creates sperm, stores it in his epididymis, eventually it works its way up from basically the bottom and the side of the testicle, works its way upward over the top of the pubic bone in front of the pubic bone underneath the fat layer there, and then over the top of the bladder, comes around from the back side of the bladder and then merges in there to the ejaculatory duct in the prostate, and then it feeds its way down through the urethra out at the end of the penis. So there's lots of other anatomical items we could point out here. You have obviously the spongy tissues of the penis, which cause the erection. The prepuce, which is the head of the penis, or I'm sorry, glans is the head of the penis. The prepuce is the foreskin. And then, of course, the scrotum is the sac that hangs down below that keeps the testes at just the right temperature by raising and lowering them. There's a muscle in there called the cremaster muscle. The cremaster muscle is the one that's usually responsible for doing a lot of the elevation, raising and lowering, to make sure that the testes are just at the right temperature. The vas deferens is also sometimes called the spermatic cord, or spermatic tubule or cord, and that's the one that feeds around, brings it up and merges in with the seminal vesicle and the ejaculatory duct. And that's about it. Okay, so the male genital, or the genitalia, we have primarily external organs. Most of our stuff hangs outside of our body. Only a few minor accessory parts are quote-unquote within the abdominal cavity, so between the tubules, the ejaculatory ducts, and whatnot. But the testes hang outside the abdominal cavity. The penis is outside the abdominal cavity, so it's primarily a external process. And the testes need to be external, because if they stay inside, they get too hot, they don't produce sperm, or kills off the sperm. The urethra gets shared by the urinary and the reproductive systems as an outlet for both urine and semen, unlike in females. So, the prostate gland is located in on the inferior aspect of the bladder. So basically, think of it kind of as a valve, more or less, to allow urine out or to allow semen out, depending on the appropriate time. It's not specifically that, but you could kind of think of it in that manner. The epididymis, this is located on the posterior portion of the testes, or the testicle, and that's where the sperm mature and are stored. So they're created in the testicle, but then are sent off to boarding school, if you will, to mature and then await their marching orders. The vas deferens, that's the tube that carries the testicular secretions from the epididymis to the prostate. External male genitalia, the penis and the testes. Testes, of course, are within the scrotum. Sperm is produced in the testicle prior to ejaculation. Sperm enters the vas deferens and then into the prostate. They combine with the secretions, the prostatic secretions, and the sperm that constitutes semen. So it takes a little bit of what you get from the prostate gland and the seminal, the ejaculatory duct feeds some of the semen down through the seminal vesicle, and then semen continues along through the urethra, and it leads through the urethral meatus, or the external urinary meatus. The penis, of course, is very highly vascular, and that allows for erection. When the penis is or when the body is flooded with something called nitric oxide. Please don't confuse with nitrous oxide. Nitric oxide. It causes a pretty incredible vasodilation. Well, when you have nitric oxide kind of concentrated down there, then it causes extreme vasodilation. Blood engorges the spongy tissues and creates an erection. Foreskin is the skin, or the prepuce, is the other name for it. The skin and the mucous membrane that covers the head of the penis in uncircumcised males. Those that are circumcised, of course, have had that removed. In reality, it's more of a personal preference thing anymore. Of course, it was primarily a religious thing for many centuries. Then it became considered more hygienic to have a circumcision done. So anymore, there's continues to be a debate on whether or not it's appropriate. So there's even been some people who have called for leaving it really up to the person as they age. So instead of doing a circumcision during infancy, leaving it up to them later in life to do that. It's kind of all a personal decision that people have to make. And we switch gears and we look at the female external genitalia. Remember, most of the female stuff is on the inside. We just have the little bit on the outside there. We have the prepuce, which is the hood of over the clitoris. Clitoris, primarily a stimulating organ. It's a very lots and lots of nerve endings in that. You have the mons pubis, which is the skin and yet generally hair-covered area to the front. Then you have within the labia majora and the labia minora, you have the urethral opening, or the external urethral meatus, and the vaginal introitus, or vaginal opening, and then the vestibule. Vestibule is pretty much everything within the labia majora, so within the vestibule would have the urethral opening as well as the vaginal opening. And then you have the perineum, which separates really the vestibule from the anus. But where the business actually occurs in reproduction for the female is really all internal. So, excuse me. Okay, so continuing. So again, most of the female reproductive organs, the actual reproductive part of this, is internal. So as we go from the bottom side here, where we have the vaginal orifice, it tracks up the vagina to the cervix. The cervix is the muscular opening, or actually the muscle around the opening of the uterus. The uterus is the place, or commonly called the womb, where the implanted embryo will then starts to form and become a fetus, and that baby grows in there for approximately 40 weeks. It is fed from the ovary, is where the egg is produced, and it is fed down, basically kind of sucked up by the fimbriae of the fallopian tube after the egg is ejected from the ovary, fed down the fallopian tube, and in theory is fertilized generally within the fallopian tube, meets up with the sperm in the fallopian tube, and then finds its way down to a hopefully nicely prepared spot within the uterus for implantation. Now, obviously, you have the other organs around there as well. It shows the rectum and the anus. In front of, between actually the uterus and the pelvic bone, the symphysis pubis, you have the urinary bladder and the urethral, or the urethra that feeds down to the urethral meatus. And that, in a pinch, is the internal female reproductive organ. So, actually, if the woman has not recently been pregnant, the uterus and fallopian tubes and ovaries actually are very small. They'll fit in the palm of your hand, basically. So they're not terribly large organs. So a gynecologist is the physicians that look at pregnancy-related disorders, the female genitalia, and all the female, general female reproductive system. Obstetrics or obstetricians, and a lot of them end up being OB-GYNs, so obstetricians and gynecologists, but obstetrics is very specifically related to pregnancy. So the external female genitalia, like I mentioned, the mons pubis, labia majora, minora, clitoris, the prepuce. You could also throw in there the perineum. So the urethral meatus, it lies between the clitoris and the vaginal introit, and it is a short route from that urethral meatus to the urinary bladder. So we're really talking about an inch or two at really the most. Hence the reason why females tend to suffer so many more urinary tract infections is because they have a very short urethra, and it's easier for pathogens to work their way up it into the urinary bladder. The urinary bladder lies so much closer to the outside world. The vagina is a hollow tubular passageway, connects the external genitalia with the internal genitalia. It also serves as the birth canal for when the baby is being born. From the vaginal opening, be posterior to the anus, is separated by the skin called the perineum. And the uterus, a small muscular organ, is lined with an endometrium on a monthly basis. That tissue thickens and is prepared for implantation. If implantation doesn't occur within a specific time period, then that lining is shed in the menstrual cycle, or the menstrual period. So that lining, as well as some tissue and blood, are shed, and the woman has her period. So the uterus, that upper portion is referred to as the fundus, the lower portion is the cervix, and then of course you have the body of the uterus, which is the majority of it. The cervix is the passageway for sperm to enter the uterus and then travel towards the fallopian tubes. It also becomes thickened and closes up very tightly when there is a baby on board. So when you have a baby in utero, that closes up and kind of becomes the bottleneck there, of course. And then there's a mucus plug that forms within there that separates the outside world of the vagina from the inside world of the uterus. So it provides kind of a barrier there. So we hear about ladies who have lost their mucus plug, or they have their bloody show. That's what happens, is they've lost that little bit of tissue that filled the gap in the cervix. That does not always occur with the breaking of the bag of waters, but in many cases it does. So. All right, so if sperm is present, then fertilization can take place. It's supposed to occur within the fallopian tube. Most cases it does. Occasionally it occurs in the fallopian tube and then backs up and goes actually backwards and goes out the fimbriae and finds its way to something inside the abdominal pelvic cavity to latch onto. That obviously is not going to work. The environment outside there is not suitable for growing a fetus. So in those cases they have an ectopic pregnancy. However, they're usually pretty self-limiting. It's hard for them to continue to go there. If not, you can have a severe ectopic pregnancy that occurs out there that causes some pretty nasty side effects. It's fairly rare though. And then in most cases, like I said, it travels down the fallopian tube, finds its way to the uterus, implants in the wall of the uterus there, and hopefully grows to its 40 weeks and then is born. Although ectopic pregnancies can occur in various other places, if the egg implants within the fallopian tube, if it implants along the cervix, those are a couple of places that it may. Sometimes it tries to attach itself to the ovary itself. So there's other places that it can occur. Hopefully it doesn't. So the ovaries and the endometrium undergo a cyclical or monthly change. It's their menstrual cycle. It's roughly 28 days, but it kind of depends all on the woman. Day 1 is considered the day that bleeding begins. So the very first day of their period is the first day of a new cycle. So bleeding roughly lasts 5 days or so. Again, varies from person to person. Some it's 3 or 4, some of them it's 7 or 8. But bleeding lasts for roughly 5 days. And in reality, a total amount of blood loss is only around 30 milliliters. If you ask females, they will laugh and scoff at that and say there is no way it's only 30 milliliters. But It's roughly 30 milliliters. Ovulation, it occurs 14 days after the first day of the menstrual cycle. So if we said on this slide bleeding lasts for about 5 days, in theory 9 days after they stopped bleeding is when they are ovulating. So, but if you just count really 2 weeks out from roughly from the time they started their last period is when they are fertile and going to they have a mature follicle that ruptures. It's discharged into the pelvic cavity near the entrance to the fallopian tube. The fimbriae kind of sweep it in theory, and then send it down the fallopian tube. If the sperm is there, it can result in fertilization. If it is not, it just continues on down into the uterus and will either be shed with the lining if there's no other, if it doesn't end up getting fertilized within its really about 2-day, about a 2-day, 3-day window in there that they're fertile. Otherwise, then if it is fertilized, then it's hopefully going to implant. So Menarche starts around age 12. Menarche is the first menstrual period for a female. I've heard these go about as low as, say, 8 or 9. Those are fairly rare, but you know, that 10 to 12 age range tends to be fairly common. You may have some late bloomers that are 14, 15, 16 before they have the menarche. Menopause is the end of a woman's, in theory, fertile years, although once in a while things do happen. The average age of menopause is age 51. So some women it's much sooner. It's in their 40s, easily into their 40s. And some of them it actually occurs closer to 60. So again, a lot of these are averages. So an advanced EMT may need to transport or monitor a critically ill and injured patient whose fluid intake and output must be monitored to assess kidney function. This is done by carefully keeping track of the amount of fluids placed into the patient and the amount of urine produced. So if we're dealing with something along those lines, we have to watch what goes in and what goes out. So a lot of times in hospitals, we will see cups that have gradations on them. Those big plastic mugs you get if you're an inpatient in many hospitals have the gradations on them, so they can kind of get a pretty good guesstimate of how much intake they have on a daily basis. And they'll record that every time they refill it. And then if they're measuring urine, they're either going to measure it in something like a urinal that has the gradations on it. Could be they measure it in their Foley catheter, which has the various gradations on it. The probably easiest way to measure it is after they've collected it, in whichever way they do, not including directly into the toilet, is they have something called a graduate, and it is a precisely marked, usually somewhat triangular shaped container that they can measure the urine and record it and dump it. So if you're transporting people and they're on fluid precautions, they're on I&Os, you're going to have to keep an eye on that. So it's a good idea when you start transport to note how much fluid was in the bag, and when you end transport, how much fluid was in the bag. And when I say how much fluid was in the bag, I mean both the IV bag and the catheter bag, if that's something that is of concern. So a general approach to our patients with urinary system disorders. We're going to be looking for clues to that patient's problem. They may not be immediately jumping off the page at you, but things like a dialysis shunt or a fistula can give us a good idea that this patient has a renal issue. Look for things like graduates and urinary catheters. They may have a leg bag just because they have a urinary catheter doesn't mean it's this big giant circle bag that hangs off the side of their bed. Sometimes there's a smaller bag strapped to their calf that urine drains down a tube and stored there in their calf, and then as need be they empty their urine bag. Also, if we're picking up patients at a dialysis center, that should be a huge red flag there. Looking for things such as hematuria. Have they had any urine with blood in it? Complaints of like flank pain and so on and so forth. Chief complaint. A lot of times I said this might be something like shortness of breath, but it's actually from a fluid overload. Altered mental status, changes in urination, weakness, those sorts of things potentially form your initial impression, which in most cases, like I said, is not going to be that this is a major emergency. Some additional things. Dialysis access site, also called a shunt or a fistula. This is where they've artificially connected an artery and a vein, and that's where they're going to puncture with needles to draw blood off and then put blood back into them from their hemodialysis. Peritoneal dialysis, on the other hand, is fed in through a catheter in their abdomen, and then occasionally people with hemodialysis will have a red and blue IV central line catheter coming out of their chest wall. So try to note things such as a fishy or an ammonia odor. Those occasionally are associated with renal failure because they're not able to get rid of that easily through their urine. They have to do that every once in a while when they undergo their dialysis. We talked about those scene size up items. So some signs and symptoms of renal failure on the fluid and electrolyte side of things such as hypertension, hypotension. So they could be hypertensive if they haven't had dialysis in a while. They're potentially hypotensive if they have recently had hemodialysis, because a lot of times they take more off, and that puts the patient kind of in a negative zone for a short while there. However, they very quickly will make up for that negative and will jump potentially to the hypertensive side by the time they're ready for dialysis again. Peripheral edema, particularly in the dependent areas, small of their back and their legs. Ascites, which is fluid in the abdomen. These are people that look like they're pregnant. Their stomachs or their abdomens are just as tight as a drum. Could have some rales or crackles in their lungs. They may have impaired blood clotting. They may easily bruise, could be anemic. Headaches, altered mental status from the toxins starting to build up, or the hypertension for that matter. Weakness, muscle cramps and twitching. Oftentimes when they're pulling off lots of fluids and waste products, they're also pulling off excessive electrolytes, or they have an imbalance where they have excessive electrolytes, more than they need. So, osteoporosis, they can have issues with loss of calcium and whatnot. Loss of appetite, nausea, GI bleeding. Not terribly uncommon to see renal failure patients with GI bleeds. Skin, pruritus. Now we're going to touch on in the immunology chapter. Pruritus is itching, scratching. Uremic frost, where their skin actually kind of gets almost a white, chalky layer or powder more or less on it, where it's their skin's attempt to get rid of some of those toxins. Pallor, rash, the odor of ammonia. They may have some immunosuppression and some infections. These are people that are regularly exposed for longer periods of time to healthcare settings, not to mention can't get rid of a lot of their waste products very easily. Also, a lot of people end up with kidney transplants, and with kidney transplants they're going to be immunosuppressed. And then obviously a decrease in urine output. That hopefully should be one of your first signs that they haven't had a lot of urine output recently. Primary assessment, again, the ABCs. I mean, we can't emphasize that enough. Maintaining good open airways, ventilations as necessary, oxygen to keep their saturations above 95, or 95 or better, I should say. Assess the adequacy of their circulation, so making sure that they're able to move blood easily, because sometimes they're very hypertensive. They may be hypotensive. They could have a fluid deficit. Electrolyte abnormalities. If they have had dialysis, they can take off too much, or if they miss dialysis, they can just simply be retained too much. So they have to be very careful on a lot of their diets. So can result in various dysrhythmias and a reduced cardiac output, because the different electrolytes play different parts in the whole muscle contraction system, and with that, patients may have very, very slow heart rates, could have very slow movements, could have hyper-exaggerated movements, or very quick heart rates. So, bleeding. Bleeding is usually a problem with hemodialysis patients. They're talking fairly good size 16-gauge needles that are being placed into these patients to take blood out and put blood back in during the process of hemodialysis. In hemodialysis, they take the blood out, they spin it through a machine. It takes 3 to 4 hours, most cases, of constantly cycling blood in, cycling blood out, and they're constantly kind of changing solutions, which is referred to as diacylate. The diacylate is using the process of diffusion to remove these toxins. So it will be free of many of this fluid is free of many of these toxins, but it will have the level of the various electrolytes and other nutrients that the body wants to have in it. So the body says, oh, well, there's no ammonia over there, so send some over. There's no there's no salt over there. There's no water over there. The water balance is off. So it bleeds across this membrane and tries to even things out through that whole equilibrium zen thing that we've talked about ever since we started this course. So they will, through this process of constantly changing it out, eventually dump off a good majority of their toxins. Obtaining baseline vital signs. Be careful of the patient with the dialysis shunt to avoid taking blood pressures in that extremity. I will post a picture in the course page of a patient that has had some. Actually, there is already one there. If you go back to the IV, when we did IVs back in week 1, there's a supplemental IV lecture, and it has in there an example of a patient with a dialysis shunt. So otherwise, if you do a Google search for dialysis shunt or dialysis fistula, you'll come up with lots of those. So avoid taking blood pressure in that arm, because it really messes up the fluid dynamics and lymphatics. So if they're unresponsive, we're going to shift gears, kind of go into a rapid survey mode here. Get them looked over quickly and on the way to the hospital. Focus our history on our alert patients to that of our chief complaint. We're going to look for signs of dehydration or fluid overload, so dry, cracked mucous membrane / tongue. Maybe they have tenting of the skin that would give us some indications that they're dehydrated. Maybe with a fluid overload, we'd have things such as crackles or peripheral edema, maybe even JVD. Oh, shoot. There we go. If you're allowed to, you can go ahead and attach cardiac monitor and monitor those patients that have renal disease. for basically electrolyte disturbance is what we're looking for. And in most cases, like I mentioned, diabetics commonly have issues with kidney problems, particularly those that remain unmonitored or don't do a good job of taking care of themselves. So checking the glucose certainly could be appropriate. Remember, if the mental status is altered, we check a glucose, period. Okay, their mental status is altered, check the glucose. If they're a diabetic and having some other symptoms, it's probably a good idea to also check blood glucose, just to be safe. Doesn't have to be a diabetic reaction, so things like stroke, drug overdose, check a blood glucose. Note their skin temperature. They can be febrile. It doesn't necessarily have to be febrile. The absence of a fever does not rule out a UTI, doesn't even rule out urinary sepsis. Sometimes they have something called cold sepsis, in which they don't generate a significant temperature. Remember, if they have vasoconstriction on the periphery because they're hypotensive or a little bit shocky and they're running a fever, they may feel cool to you to the touch. Changes in urine, urination patterns or color of their urine. So we might even ask things in the case of babies, how many diapers have they had? Are diapers the normal amount as usual? The closer that urine is to clear, generally the more fluid there is, the more water there is, and it's diluted. It's much more diluted than is something that is a dark amber in color, in which there's a lot of solids, a lot of waste, little water in that urine. So. And then difficulty, inability, painful, more frequent urination, those all can give you additional suggestions that there's a urinary tract issue. Not always is it. Pain or more frequent urination may actually be a sexually transmitted disease or sexually transmitted infection. Inability to pee, it may not really truly be a urinary issue, sometimes a prostate issue, which is taken care of by urologists, but in the classic sense that we're talking about in this course, it's not an immediate urinary issue. Eventually it's going to become very uncomfortable, but there's not much we can do about that. So blood in the urine, of course, is kind of a scary thing. Very, very dark colored urine. Sometimes it's almost brown. If it's cloudy, cloudy means there's more stuff present in it. If it's completely colorless, maybe suggestive that they're just water running through them. Now, let's say you drink lots and lots and lots and lots of water all the time. Your body's going to get rid of the excess amounts of water. You eat well. If you're eating well and not creating lots of waste products, then you could be just fine. It may be a non-issue. So just because you have any one of these things does not always mean that it's a major issue. So it's looking at the whole package and the whole picture. Look at what their past medical history is. Check their medications. So are they on things like diuretics, or they take things like charcoal? You'll see things called charcoal caps, where it's actually an activated charcoal that helps their body absorb some of the toxins. It kind of helps out the urinary system. So, and then there's a few other things that help improve blood flow and whatnot to the kidneys and make them work at their best. With our clinical reasoning process, patients with renal disorders often have other medical conditions. Most people are not solely kidney patients. Like I said, many of them have hypertension. Many of them have diabetes. You may have cardiovascular issues that the person has. Maybe they have, remember, they may also have a transplant. So most of them are fairly complicated in the grand scheme of things. Renal problems can impair homeostasis. It affects organ syndromes. or systems. If you've got lots of salts, you have an abundance of water, you have all this ammonia, it just muddies the waters. It makes things much more difficult for patients to function at their best or at their capacity. Kidney transplants, medications to prevent rejection, that will cause immunocompromise. So they will not be able to fight off infections like other people will. Foley catheters. Foley catheter, if you see a patient with a Foley catheter and they have an altered mental status, one of the first things after you say, is this person a diabetic, and you check the blood sugar, one of your very next thoughts should be, does this patient have a urinary sepsis? Look at the bag. Look at the tubing. What do you note? I have seen many people with indwelling Foley catheters that just have gross tubing and gross bags. Greens and oranges and cloudy yellows and solid stuff, pus. There's some pretty ugly, nasty stuff that you will see in some of these Foleys. So you've got something that's green and chunky in there, and the patient is unresponsive with no blood pressure, very little blood pressure. They have a fever, and they have tachycardia. You should strongly be suspicious this patient has a urosepsis going on. So it's not 100% conclusive, but it's strongly supportive. Treatment. Anemia is also a very frequent complication of the disease. Be cautious with fluid administration. We may think, oh, well, they're anemic, so I want to fill up their vessels in some cases, because remember, some cases they're low on blood. So if I want to fill up their vessels, that helps them circulate better. However, not all anemias are from that, and it is very easy for us to fluid overload kidney failure patients. So people with congestive heart failure and renal failure are the ones we have to be very cautious with the amount of fluid that we give. If we're going to give them larger volumes of fluid, we have to do it in baby steps. So 100, 200, 300 cc's at a time, recheck their lung sounds, recheck their vital signs. Maybe we can give them a couple hundred more then. So it has to be in baby steps, otherwise we flood them. Check their breath sounds frequently for the fluid overload. Do not give additional fluids to renal patients who have crackles or rales in their lungs. So remember, during reassessment, we're reassessing all those normal things: mental status, vital signs, physical findings, treatments that we've performed. Those are all things that we need to constantly be re-looking at. Reassessing critical patients every 5 minutes at a maximum, and every 15 minutes at a maximum for our non-critical patients. Okay, back to our think about it. So we can go in and talk about some various renal disorders. So these are issues, problems, diseases that involve the kidneys. So complications of diabetes or hypertension are very common. They can be acute or they can be chronic. Sometimes people have an acute renal failure. It's kind of an isolated event. It comes, it goes, whereas with chronic, they start down that path, and generally the path doesn't get any smoother for them. So this affects their kidney filtering. We can have things that are outside the urinary system that is actually the problem. Maybe it's hypertension. Maybe it's a problem with our body creating too much of a certain hormone. Maybe it's the diet, with the amount of fluid intake a person gets. There can be things within the kidney, which are referred to as intrinsic. So you have the kidney failure itself. The tissue starts to break apart, polycystic kidney disease. You have after the urine leaves the kidney or post-renal. So urinary tract infection be the main one there. Occasionally for gentlemen, I guess would be, if we think about it, in a less emergent sense, prostate issues. So renal failure is categorized by the amount of urine still made by the diseased kidney. So they will monitor this, and again, they're doing those I&Os, intakes and outputs, where they're closely watching what goes in, what comes out. They may have oliguria. Oliguria is they create lots and lots and lots of urine. So they have this excessive amounts of urine that they put out, and that it may be large amounts of really basically unfiltered urine that they're basically just dumping lots and lots of extra water. We may have something as anuria. AN, remember when we stick A or AN on something, it usually means that the patient is not doing whatever the AN is attached to. So this would be not creating any urine. So the other extreme is creating this excessive amount, creating greater than 400 to 500 mils in a 24-hour period, or 20 mils an hour of urine. But there are still indications of renal failure. Then it's called non-oliguric renal failure. Actually, I misspoke earlier when I said oliguria is lots of urine. Oliguria is it's making less than 400 to 500 mils in a 24-hour period. The anuria is basically none. Non-oliguric is still creating a decent amount. And then we have polyuria, and in polyuria, that's when we're creating too much urine. And remember that to say a common sign, or actually symptom in diabetics, is they're frequently urinating. Acute renal failure, or ARF, I think that's one of the coolest acronyms, but ARF, this is a loss of renal function, decreased glomerular filtration rate over hours to days. Sometimes this is a very short-term thing, sometimes it's a much longer term. They're going to start accumulating a nitrogen containing waste in the blood. It's measured by looking at something called the BUN. People call it the BUN, but it's blood urea nitrogen. So they're also looking at another test called creatinine, not creatine. Creatine is for those of you guys that think that need to be bodybuilders. But creatinine, and these are measurement of the various waste products of the body and how they're being affected and controlled by the urinary system. So when levels of those substances are increased, it's called azotemia. And then when the signs or symptoms of renal failure accompany azotemia, then that condition is called uremia. So azotemia is the presence of some of these substances in the urine, which doesn't automatically mean renal failure. You have to put the clinical presentation with it to call it uremia, which is renal failure. So in acute renal failure, you have pre-renal renal failure, so issues or disease elsewhere in the body affect that kidney's ability to produce urine, and that's approximately 60% of the time, which somewhere prior to it getting to the kidney, so a lot of times maybe a hormone issue is affecting it. The intrinsic disease, or the actual kidney itself, is approximately 40%, and then somewhere in the 5% of cases we have the cases of a post-renal issue. Once in a while things will back up. There will be a stone or something that backs up and causes there to be some basically some congestion in there that will cause stagnation of urine. It can cause some damage to the kidney, of course. So a few other things that get thrown in here, as you can see on page 636, some of the things they're going to be looking at in your potential renal failure patient, the presence of a number of things on their blood tests. Urea in the form of usually BUN, blood urea nitrogen, creatinine, potassium, hydrogen, sodium, phosphates. They're going to look for presence of some other toxic substances. They'll be looking for the presence of other chemicals such as glucose. They'll be looking for some blood, some things that they're going to be looking for there. They don't always test for all of these, such as the electrolytes aren't. The potassium, the hydrogen, and the sodium are not always tested on those things, but they're going to monitor those usually in an electrolyte panel. So it's not necessarily one set of tests. It's a panel or a series. So when we talk about a post-renal acute renal failure, that's that bladder outlet is obstructed. So if you would have for some reason a blockage somewhere, whether you have a tumor that has grown there, you've had for some reason an incredible spasm of the various sphincters that won't allow urine out. Maybe there have been cases in which people have held their urine for hours and hours and hours and hours, and then it came back to haunt them because they could not get rid of it. Get this backflow of urine into the kidneys, and then the kidneys are sitting there in this soup of waste product. So acute obstructions, the patient can be really in an agonizing pain. They're unable to urinate. Sometimes it takes kind of busting a catheter with a rod in it up through one of their sphincters to get it to dilate so they can actually get rid of that extra urine. There are other ways to do this. They can take a long needle and puncture through the abdominal wall into the urinary bladder, drain it off that way. There are some people who have a type of catheter called a suprapubic catheter, where your urinary catheter actually doesn't come out of the urethral meatus. It actually comes out of their abdominal wall. It's much like a colostomy bag, with people that defecate into a bag through their abdominal wall. There are other occasional weird things you'll run into. A nephrostomy, where they'll actually tap urine directly from the kidneys and drain it off there. So if we have this patient who can't urinate, they're in tons and tons of pain, giving them IV fluids is only going to make this situation worse. So an IV lock at the best and call it good. In intrinsic acute renal failure, that's when that kidney itself is starting to give out. So glomeruli are shot, tubules are starting to wear out, the interstitium is starting to fall apart, those renal blood vessels are not working well. So there's a variety of things obviously that can lead to this, but basically understanding that the tissues are just worn out, and in most cases it's as a result of either a systemic insult or infection, or somebody who simply just didn't take care of themselves well. Some other weird things that can occur, you can have systemic lupus erythematosus, which we talk about more in the not infectious disease, but the hematology and immunology chapters. The systemic lupus erythematosus, it's an autoimmune disorder that kind of breaks up connective tissue, and it very, very, very commonly attacks the kidneys. So it can put a person into renal failure, and in a lot of cases people do come out of it. They get their lupus under control and their kidney function returns to normal. In some cases it doesn't, though. There's those tubular disorders. Maybe you have toxins or ischemia has caused the tubes to kind of die off or become leaky, and in those cases obviously it's not an efficient process anymore. Medications, obviously we can overdose on certain medications that will wipe out our kidneys, because that's really one of the things that they are hit hard in overdoses. So things such as NSAIDs can be problematic. It can really affect the kidneys a lot. Things like Tylenol affect your liver, and the NSAIDs, the ibuprofens and whatnot, attack your kidneys. So can have vascular renal disorders, so blood clots. I've mentioned that way back in the beginning of the chapter. You can cut off blood flow. Common cause of renal failure in older adults, where they're a little bit those people that are more prone to blood clots. You know, they're on steroids, or not steroids, hormone therapies. They're unhealthy. They're overweight. They're smokers. They're recent surgeries, recent traumas, inactivity. All that stuff tends to lead to blood clots. You also may have renal artery stenosis. Stenosis is a hardening and a constricting of an artery. So this becomes a very difficult, non-pliable artery. It doesn't do a great job of supplying the kidney with the appropriate blood. So it may be a reversible cause of hypertension. You may have a renal hypertension where this person just simply needs some vasodilation to help relax that and allow it to open back up. So when you're managing the acute renal failure, remove the offending agents. So, you know, if we have persons that are taking certain drugs or have various issues going on within their body, we take that away, remove it. Maintain their fluid status as close to normal. You have to be very careful that we don't overload them. Any type of renal failure can leave the patient without functioning kidneys and can require dialysis. So sometimes people are going to end up on dialysis regardless. So hopefully it's a short-term thing, and then they'll bounce out of it, we hope. However, then there is chronic renal failure. So chronic renal failure can come as a result of acute renal failure. It is an irreversible kidney dysfunction. It increases with increased urea in the blood for greater than a 3-month time period. So this is over a longer period of time. This patient just can't handle it. So there's all these retained waste products in the system making everything toxic. And remember, our kidneys don't only control urine, water, and so on, but they control blood pressure. They have various things that they secrete, such as epoetin, which has to do with our blood. It has renin, which has to do with the renin-aldosterone angiotensin system, which is potent vasoconstrictors. Activates vitamin D, which helps in various manners in the body, mood, and the use of calcium, and so on and so forth. So putting extra pressure on the kidneys can really have a major effect over the patient's well-being. Uremia. Uremia is urea that's not getting excreted by the kidneys. Commonly the person will have kind of a fishy odor about them. Nausea, vomiting, diarrhea. The body knows it has too much waste. May have GI bleeds. Heart failure, dysrhythmias, edema, blood clotting, pericarditis, pericardial tamponade, neurologic signs and symptoms, skin rash, itching. So it's pretty obvious looking strictly at this slide alone that with all this excess waste building up in the body, everything starts to take a dump. So we've got cardiovascular here, we've got GI here, we've got the skin involved here, we've got the neurologic system involved. So it doesn't take very long retaining these wastes to really make life hell for people. ESRD, which is end-stage renal disease. This is when the patient is considered for transplantation or occasionally for permanent dialysis. Some people are deemed not suitable for transplantation. This is a result of hypertension in at least 23% of the cases out there. It can also be from a glomerulonephritis, so they get some sort of an inflammation of the glomerulus. Maybe it is an infection, which is a very ugly thing to see occur in your kidneys, because that's supposed to help get rid of a lot of the waste products of infection. Might be polycystic renal disease, in which it's basically a hereditary thing. It pops up later in life, where you develop the cysts within the kidneys, and it disrupts the nice easy flow. Not to mention the tissues themselves are just not as strong as they could be. Here shows an example of a shunt graft for hemodialysis. You see where they've come off of an artery and a major vein. They've connected them together, and that's where they're going to access the patient to take out and put in blood for dialysis. You can see this picture on 639 in your text, and this next picture as well. This lady does not have a shunt in her arm, and that's where they are in most cases, is in the forearm. Occasionally they're in the upper arms. They also can be in the legs. But this lady actually has the IV version of this, so she has an implanted catheter in her chest. If you look closely, you can see there's a blue adapter right on that white chucks, right as it's coming out of her shirt there. There's a blue cap and there's a red cap, one of those obviously being a vein, one of them being an artery. So they know to hook up the correct ones. So blood comes out, it gets spun through this machine, and it's a pretty good sized machine there with all kinds of little filters, and there's different fluids that run through this. You can see just barely in front of the machine on the floor there's a big bottle of diastolate that they'll use in this machine to pull off the toxins again. So with hemodialysis, this person has this catheter placed, whether it's a shunt or what, and the arterial blood leaves the body to enter the tubing, conducts it to the hemodialysis machine, and then the dialysis removes that waste from the blood, leaves the patient at a higher risk for infection, leaves them at a higher risk for bleeding. The blood, they don't go on to tell you that the blood is then redeposited back in through the vein and returned to the heart. But so nice clean blood is hopefully on its way back up to the heart. The blood clots are potentially a big issue. You also have the other side of it, in which you have bleeding disorders. So it depends on that patient, their conditions, their medications and whatnot. Higher risk of infection, and of course in the case of the lady with the one implanted in, well, actually any of them, but I guess it's probably a better case to discuss the lady with the line in her chest. That's going to empty right into the heart, so you very easily can spread infections. Malnutrition can be an issue. Psychologically, they can have issues because they're very depressed and down about their condition, not to mention sometimes the chemical imbalances kind of make things a little bit more emotional. Hypotension, hyperlipidemia, pruritus, skin rashes again. Hyperkalemia can cause cardiac arrest in patients with renal failure. This is one of the more common populations that an electrolyte imbalance has such an excessive and severe issue with the patient. There's also peritoneal dialysis. While it's probably not nearly as common for us to see, and it's not a very good picture, I guess, if you look on page 640 in your text, you can see a representation of how peritoneal dialysis works. Peritoneal dialysis, they have a catheter through their abdominal wall, and their diastolate is basically infused into their abdomen. So their abdomen kind of swells up a little bit. They fill their abdomen with this fluid, and then in that process, the toxins again shift into that fluid. The fluids stay right there in the abdominal cavity. They don't migrate anywhere. And so then the chemicals, the waste products, diffuse into their diastolate there, and then later, after they infuse their abdomen with some of this fluid, they'll go back and then they will drain their abdomen and take that fluid back off, so then the patient doesn't have to undergo the hemodialysis. However, people with hemodialysis have to go every other day, or really no more than every third day. A lot of people on peritoneal dialysis are doing this at least once, if not several times a day. A lot of them do it while they sleep. Some of them have little pumps and whatnot that kind of help operate the whole system. But they can have a little bit more freedom and independence by staying around the house. But they have to be watched kind of closely, particularly if they have episodes in which they become acutely ill. Because peritoneal dialysis, while it works for fairly healthy people, people that are less healthy, it's not as efficient. So, all right. Oh, I guess one more thing I mentioned there: hypertension is not a general side effect, because we're not taking blood off, we're not taking excessive amounts of fluid off. It's really more pulling the toxins off, but the fluids generally stay pretty stable. So renal transplant, or a kidney transplant. So if we're talking about patients got that end-stage renal disease, there's a greater need than the number of organs available. This is common with all organ transplants. First-year survival for people with renal transplant is 85%. It's a very good survival rate. People tend to do pretty well after kidney transplants. Remember, you only need one kidney to survive, so it's not like you have to go in and replace both of them. A lot of times people are able to give a kidney to a loved one because they're a fairly close match. And people will very quickly start to perk up after getting their kidney transplant, because they're now so much more efficiently removing their waste. So the kidney will be placed in the lower abdomen and attached to the iliac arteries, and the kidney can sometimes be felt on an abdominal exam. They don't always go and just tuck it back in that pocket. And then post-transplant patients will be on immunosuppressants. So you have to have it, because it's not your DNA. Your body's not going to like it. It's going to want to reject it. So they get the immunosuppressant medication, because the DNA of that kidney is different. One potential exception to that might be as if you had an identical sibling that was able to give you a kidney, in which your chances of rejection are going to be very, very low, because if you're identical, you have basically almost identical DNA. So, and it mentions that cardiac causes and infection are their most common causes of death. So, other things: steroids, cyclosporine, tacrolimus, alemtuzumab, and mycophenolate being common medications that these people are on. We talked about in the immunology chapter a little bit more about some of these immunosuppressants. And then they also may be on some medications to cause adrenal suppression, and they'll have poor wound healing, osteoporosis. They're very susceptible to infection. It also has some effect on their skin, their hair, and their posture. So it's not, getting a transplant is not without some potential negative side effects, but it generally is a better life than not getting one. All right, so a few other things that pop up from time to time, say in the male genital urinary disorders: acute urinary retention, which is abbreviated AUR. Usually the biggest issue here is benign prostatic hypertrophy, or BPH. So these guys that get this enormous prostate gland, and this prostate gland, remember, wraps around the urethra and so as it continues to grow or hypertrophy, it puts inward pressure on the urethra, makes it more difficult to urinate. So as it grows, it prevents the easy flow of urine, and that backup of urine in the bladder is going to cause some discomfort. It can back all the way up through the ureters into the kidney, which can then cause some renal failure. Also, you may have a nervous system issue in which the spine injury causes an overdistension of the bladder because the person isn't able to feel their urge to urinate. When a certain part, the lower part of the urinary bladder, called the trigony, is got stretch receptors in it, and as that starts to get extra pressure and stretch on it, that's when these patients will start to complain of, or not complain, but that's when when all of us start to feel the need to urinate. Well, if you don't have the innervation to that, and you feel this stretch, and you feel that pressure, you may not even know you need to urinate. So we're giving them lots and lots of IV fluids. We're just going to make this problem worse because they can't let their urine down. Renal calculi or renal calculus, that is the medical term for a kidney stone. So a renal calculi or calculus. The composition of the stone varies. Many of them have a calcium base to them. So it's a little different than gallstones, where gallstones tend to have a little bit more of a fatty composition to them. Kidney stones tend to have more of a mineral composition to them. And the composition of that stone, like I said, it varies, but can generally pass through the lower urinary tract as long as they are less than 6 millimeters in size. 6 millimeters in size is pretty good size of a stone to go firing out of a little tiny tube. So renal colic. Renal colic is the pain that's caused by stretching and dilation and irritation of the ureter due to the muscle spasm from this little cockleburr creeping its way down through the system. Men more often get this than women, and the most common age group to see it in is ages 35 to 45. It can affect any gender, it can affect any age. Some people in their 20s will end up with kidney stones, or even in their teens. So it's not strictly something as you age you become more likely to get. Certainly seems that way. So it will present, the patient will present with a constant severe flank pain, usually radiating into the groin. So it kind of starts in their low back, comes around the front down towards their groin or their pelvis. Also sometimes you'll hear particularly men complain of pain at the tip of their penis, kind of as a referred pain from this. They may have some tenderness all throughout that general area, blood in the urine, painful or absent urination. You got to consider some of the differential diagnoses that go with it. You know, if you're complaining of lower back pain, could it be a AAA? Are you complaining you have a female who has flank pain down into her lower pelvis, usually around one side, particularly if it were on the right side? Or actually, I should say, on the right side, male or female, could it be an appendicitis? Could it be, left or right? It could be in a female, particularly of childbearing age. Could it be something like an ectopic pregnancy? So there's a lot of things that it could potentially mimic. Fluid boluses can help flush the stone out. Creating more urine, put more water behind it's going to help move it along. No, it's not going to be comfortable. It just doesn't happen. But you can do things such as consider giving them some nitrous oxide to help alleviate some of that pain. It is very painful. I've never had it. Talked to many people that have, seen a lot of people who have had it. but it is not particularly a fun time for most people who end up with kidney stones. UTIs, urinary tract infection, this actually is more common in the female population than it is in the male. But urinary tract infection, remember I said in the female is because of their significantly shorter urethra. It's easier for bacteria to get up in there. Very, very common in patients with indwelling Foley catheters. There is a picture, actually we got it coming up here, a picture coming up in a couple slides that talks about, shows us how urinary catheters work. I'll talk about it for a minute when we get to that. It can affect everything from the urethra, prostate, urinary bladder, even sometimes up through the kidneys, or up through the ureters, and in severe cases get their way up to the kidneys. You can have a urethritis. Urethritis is a urinary tract infection that basically affects mainly the urethra. It can be from sexually transmitted infections, can be bacteria from poor bowel hygiene. You can have infections of the prostate, which is prostatitis, difficult to get rid of. Will tend to lead to some urethral discharges. Infection of the bladder, where you tend to see more painful, frequent, cloudy, and odoriferous urine. Infections of the kidney is referred to as pyelonephritis. So if we have the patient with urinary tract infection, they're probably complaining of those signs and symptoms of some difficulty urinating, maybe changes in their urine, back pain, particularly on one side or the other, that far up in the system, or the various pain with the urethra and whatnot. Really, this is going to be transport the patient in a position of comfort. You can certainly give them some IV, give them some fluid. They don't really honestly need the fluid. This is not a life-threatening, not a make-or-break thing. But the more urine they run through the system, the more they're flushing out. So the more they pee, the greater chances they're getting rid of the extra goos and whatnot. You could consider analgesia. I'll tell you what, it's fairly uncommon for us to go to strictly a urinary tract infection. In most cases, if we're going to something that is urinary tract infection, it was a urinary tract infection a few days to weeks ago, now it's a full urinary sepsis. All right, so the Foley catheter picture, as shown on 643 in your text. The way that this whole thing works is you have this flexible tube, goes up the urethral meatus, doesn't matter if it's a male or a female, goes up the urethral meatus into the bladder. Once urine starts to pour into the tube and out the end into the bag, they're pretty good sign that they're in the urinary bladder. They usually advance the catheter just a little bit more, and then there's a port in which they inject some saline or some sterile water into that port, and it will inflate the balloon or the cuff, much like on a king airway, and that balloon or cuff kind of seals off that external opening and holds the catheter in there. It's a pretty tough little cuff on there, so if it were to get pulled out before it was deflated, that's generally not a very good situation to be in. So that urinary catheter can either be left open and drained into a test tube or a little vial in order to test it, or it's hooked to a bag. A straight catheter, in most cases, they don't have the cuff on the end. They just stick a tube up in the bladder, drain off a little urine for testing, pull the tube right back out. Whereas an indwelling urinary catheter or an indwelling Foley catheter has the cuff. It's intended to stay in there for a while. Sometimes it's going to be a little tape anchor onto their leg or something to help prevent it from getting pulled. But then it drains into the bag there. There's a little spout that you can empty it. It's got a clip on it. Hopefully keep it from running all over the place. Be cautious with these. These need to be, this works off a gravity system. So the bag needs to be lower than the patient for extended periods of time. Now, you're moving a patient from their bed to your cot and out to the ambulance. It's okay to throw it up there on the cot between their legs, and then once you get them out to the truck, out the ambulance, put the bag down so the urine can drain. For a couple of minutes, for the sake of transport, it's not a big deal. Over longer periods of time, you just cause the urine to back up, urine to back up, urine to back up. So, problems with Foley catheters. Older patients, they can be confused and can't control their own urination. People who are bedridden and can't get up to go to the bathroom, a lot of times will end up with Foley catheters. People who have problems with BPH or have had surgery on their urinary tract sometimes will have them in order to help them stay sanitary until they get a little bit more control over their urinary system. A lot of times critically ill patients end up with these. Patients with paralysis will have them. Sometimes they'll have them in a leg bag form as opposed to the full form. So we've got this, they say clear plastic tube, but that's not necessarily true. Most of the time they're actually somewhat opaque, or at least translucent. But they're inserted up in there. We got to make sure that the clamp on the tubing is released so that urine can flow fully, and of course, like I said, keep it lower than the patient. Other issues with the Foley, patients won't try to pull on them either purposefully or by mistake. Once in a while, people will get their foot wrapped up in the tubing because it's down towards the foot of the bed, and I've a couple of times seen Foley catheters pulled out by accident because somebody got tangled up in it and walked away and pulled it out. Not pleasant. Evaluate for possible blood infections and trauma. Look for signs of infection. There's so many problems with people having severe infections from their Foley catheters. So if they've got a Foley catheter, be strongly suspicious. UTIs can go unnoticed in the elderly. People aren't paying as close of attention to the habits of the elderly, particularly those that aren't institutionalized or in a nursing home. Can make them very ill. So keep a high index of suspicion. A few other weird things that happen, particularly to the male genitalia. You can have something that's referred to as Fournier's gangrene, which is a bacterial infection of the skin that affects both the genitals and the perineum, or the perineum, depending on what you want to call it, how you want to say it. Usually develops from some sort of a wound or an abrasion to the skin. Maybe it's a sore that went untreated, potentially less hygienic than they could be. Men are 10 times more likely than women to develop this, and it actually can be a fatal emergency. The appearance of it is often a small scab or a lesion that is so deeply seated in the pelvis that patients are often rushed into the OR to be debrided. The symptoms you might find include crepitus around the scrotum and the perineum. So you kind of get this crackly feeling under their skin, kind of like subcutaneous emphysema. Pus, weeping pus, small gray lesions, foul odors, severe swelling of the scrotum and the penis, and a lethargic febrile patient. So on the way into the hospital, necessary, we throw an IV in this person. If we have the time, we continue to support their ABCs, treat the hypotension as necessary, and get them into the ER. Phimosis and paraphimosis. Both of these are a fairly serious concern. Paraphimosis is a far worse emergency of the two conditions. Phimosis is a foreskin that cannot be pulled back or the head of the penis. Urine builds up in the foreskin and causes an infection and an irritation. A paraphimosis is foreskin of an uncircumcised male that's already been retracted, and you can't get it back into its normal position, and it's constricted the lymphatic drainage of the glands. So basically, it's like putting a choke collar around the base of the head of the penis, and it's going to cause some severe swelling eventually. tissue death and necrosis, which is not particularly a great thing. In most cases, they say apply an ice pack to decrease that swelling. Sometimes people who've been around dogs for a while know that sometimes male dog's penis gets stuck outside. They say, put some sugar on it. That's going to help pull some of that extra swelling and water away, and should help it retract back in. I've not heard that working in this case. The phimosis is you can't pull the skin back, you can't retract, you can't expose the head of the penis. Paraphimosis is when you can't cover the head back up. So there are some medications in the hospital they might be able to use with this. Basically, we're just going to treat it supportively, get them transported into the hospital. Be careful if you're going to use ice packs that you don't cause any frostbite on that. That'd be kind of a real bummer. So the priapism, we're probably familiar with priapism from EMT when we were talking about people with spinal injuries, but priapism is the defined, painful, prolonged direction of the penis lasting for longer than 4 hours. So, of course, that's considerable or major consideration in patients who take erectile dysfunction drugs, is because they can get that blood to build up. They can also get it basically just traps in there and kind of stagnates. So it's unable to drain out. Sickle cell disease, these patients often will develop priapism, where the corpus cavernosa of the penis fills up with blood, and then because of these sickle cells catching up on each other and not sliding by easily, it makes it very difficult for the blood to drain out of the penis. So in addition to our traumatic injuries and sickle cell, things like leukemias, certain types of cancers, carbon monoxide poisoning, malaria, black widow spider bites, certain medications can give you problems with priapism or occlusion of that vasculature that allows for drainage. So when not treated properly, it can lead to permanent inability to achieve an erection, occasionally even amputation of the penis. So in most cases, really our only treatment for this is going to be apply an ice pack and get their butt to the hospital. It's not something that there's much we can do in the field about. Testicular torsion. All of us probably at one time or another tried to play with the yo-yo. And most people who aren't very good at the yo-yo will send the yo-yo down once, it maybe comes up halfway, and then never comes all the way back up, and it just sits at the bottom and it twists and it spins. Well, that is a torsion. So when the testicle twists around and the spermatic cord and the neurovascular bundle that feeds it gets crimped. This can also occur. You can have an ovarian torsion. It's pretty uncommon, but it can occur. So if you get a torsion, then you can start to get some atrophy and leading to death of that tissue. It's cut off all that blood supply. If that torsion is not reversed within 6 hours, there's a really good chance that testicle is going to die. So it is not a great thing. Sometimes infants in the first year of life, and boys generally aged 12 to 18 are the more common population we'll see this in. Patients will complain of nausea, vomiting, blood in their semen, lower abdominal pain, lump or swelling in the testicle. Mostly it's sudden severe testicular pain. And that sudden severe testicular pain should be a huge red flag. Occasionally they also come walking in with a bow-legged cowboy gait, where look like they just got off of riding the range on their cattle horse. They kind of have this bow-legged walk to them. It's because they're trying to keep any extra pressure off that testicle because it hurts. So we're going to compare that here with our next emergency, which is epididymitis and orchitis.
In the case of a testicular torsion or an epididymitis orchitis, you ask them to reach down and slowly elevate their testicles. So with their palm of their hand, cup their scrotum and raise it up. If it continues to hurt or hurt even worse, it's probably a torsion. If it feels better, it's probably the epididymitis or orchitis. So epididymitis, inflammation of the epididymis, remember that was the storage center, the warehouse on the testicle. Young men who have sexually transmitted infections and elderly men can develop this. Ice and elevation of the testicles will help. So again, elevating testicles helps. Orchitis is an inflammation of the testicle itself. From a field standpoint, we can't tell the difference. They're going to be tender. Potentially both of them will be tender. Mumps can cause an orchitis. So if you have somebody tell you that they have, they've been sick lately, kind of fluish-like symptoms, and their scrotum is really swollen, they probably have an orchitis, and it's as a result of the mumps. So they probably have very enlarged lymph nodes in their neck just below their ears. So that would be an example of an orchitis. So mumps is really